Plenary session 1 will start at this moment. Okay. And may I invite moderators and speakers on the stage?
Thank you so much for this invite for the four of us to be with you. Now, first of all, let me introduce myself. And I'm Gabriel Leung. I work at the Hong Kong Jockey Club Charities Trust and the Institute of Philanthropy. Huge honor to be speaking with these three distinguished individuals in Plenary 1. Now, let me recap a little bit, and then I will introduce our panelists. So remember, the key question facing all of us following the keynote from this morning and Plenary 0 just now, question is, what is the role of tech, and in particular digital tech, in the age of AI to improve public health and the achievement of UHC, universal health coverage, through a health systems perspective? That is a mouthful, but that is our task. What is the role of digital tech to bring about better public health and universal health coverage? Now, this morning you've heard highlights of the potential promise of the technology. And first, we heard about going from deep sequencing or deep seek to deep seek, which wiped off, at least for 48 hours, 7 to 10% of US tech stocks. And you also learned the experience of BGI and BKGI of the power of economy of scale. So innovation, but really centered around the economy of scale and scaling dimension. Moving the goalpost from 38 billion per genome to 1,000 US dollars per genome as a goal, to the reality of 1,000 RMB, Chinese yuan, at current prices, which is roughly 120 US dollars per genome, and the goal of pushing that one order of magnitude lower to 10 US dollars a genome. So that's the BGI or BKGI experience and achievement in economy of scale. You also heard from Ruben just now in his exposition of nowcasting what is now possible, the $99 eBay colonoscopy camera, to the crystal ball gazing, or maybe is it telescoping, of the prophecy of what AI promises from both Ruben and from Dr. Wang. That's really the background against which we are now going to open up the discussion. We've heard tantalizing hints from Plenary 0 panelists about inclusive AI, and this we heard from Phil from the Africa CDC. What does Africa-centric mean? Centricity around the beneficiaries of this technology. We've heard from Hani Kim, about equity of access and the importance of public health, going back to our key question. We've heard from Meg Davis about digital rights from a liberal lens, particularly via the young. And that is so important because for and by the youth is a key part and has been a key part of PMAC for a very long time. You have, as a co-hosting organization on PMAC's International Organizing Committee, IFMSA, the International Federation of Medical Students Associations. So now we have, let me introduce or reintroduce Hani Kim from the Right Foundation of South Korea. We have next to her Dipali Khanna, who is the Vice President for Asia of the Rockefeller Foundation. And then to her left, Thomas Palau, from previously, no stranger to this region, the manager of the health sector practice in East Asia and the Pacific for the bank, and currently special advisor to the WHO from Estonia. Now, what I'm going to pose to them and allow them to speak on as an opening statement for 5 or 7 minutes is, again, going back to address the key question: what is the role of digital tech to get us to the promised land of UHC? And with that, may I please first invite Dipali, who will share her experience of having tapped into tech in the age of AI in this region and how it relates to the current priorities of the Rockefeller Foundation. Dipali, over to you, please.
Thank you so much, Gabriel and Swadika. It's such a privilege to be here with all of you. And I want to, of course, thank PMAC for inviting me here to be in this plenary. We have been supportive of PMAC right from its inception. And it's wonderful to see how it's been growing over the years. The leaders in the room, the experts, the change makers, the innovators, who are really driving transformation in health systems. So truly, it's a privilege for us to be part of PMAC ever since its inception, and we continue to do our part to really see how it can drive further action on the ground, because that's really the need of the hour. The Rockefeller Foundation is obviously very privileged as well, and I want to welcome all of you to Bangkok. This is really the home for the Rockefeller Foundation's Asia Regional Office, and you've already tasted the warmth and the affection that you get in this country. I've been experiencing it myself for the last 10 years. The Foundation's mission has always been to serve the well-being of humanity, and we feel very privileged because we have amazing partners who've made this possible. We're strong believers that technology is really a powerful enabler, like all of you, for progress. And I'll share some of my experiences where I've experienced at work. A couple of years ago, we gave a grant to UNICEF, which is really to implement data systems, really implement how data science could be effective for community health programs, and really ensure that it reached the marginalized communities that were being provided maternal and child health care services. India was one of the countries where this work was implemented, and I was able to actually go and see what UNICEF had been able to do through this technology. So we all know in this room that, the backbone of the community health system in India is really being implemented by the community health workers, who are called the ASHA workers. You have over 10 million of them, and they literally go door to door providing maternal child health care, and also provide information on acute diseases. So their work was really tough before we started working with UNICEF. Having spoken to them, they would be carrying these heavy registers, wasting about 40% of the time just documenting information, but were never able to really make use of that information. So UNICEF was able to develop this app called Anmol, which really helped the ASHA health workers to be able to get real-time information, to be able to go paperless, and really be agile in terms of how they could be providing the real-time information that was needed by the communities and particularly the mothers. So I think it's been truly transformational. And for me, what's really exciting is that when I was in Jaipur earlier this year, in a couple of weeks before, it's just the start of the year, it's exciting to see how the government of India is now working on an RCH 2.0 with UNICEF, where they really want to have an integrated platform with family health data, and also looking at how they can really have better automated workflow processes for these ASHA workers. We also had the privilege of meeting one of these ASHA workers that is catering to about 350 families, looking after 43 pregnant women, taking care of 13 newborn kids. And to hear of her dedication and what this app has been able to do in terms of how she's delivering services is really spectacular. And it was not just talking to the ASHA health worker, but also talking to the women who were being provided the support from this health worker. So very simple technology, but truly transformational. I think when you're talking about technology, it's really important for us not to lose sight of the kind of impact we're trying to create. And this brings me to share another example, which incidentally, Gabriel has been part of that journey. We're supporting the Pastor Network through the Institute of Philanthropy. We're very, very excited about the work that we're doing with Pastor Network, where we're really trying to see as to how we can help communities be able to be better prepared when it comes to looking at the impact of climate on health. And Pastor Network, of course, in the region is located in Vietnam. They're based out of Ho Chi Minh. We're working very closely to see how local researchers, government, and the community itself can be able to have access to data that will really help them to make the right choices, be as community members, as local government, as local researchers. We have the Community and Health Accelerator project, which is trying to really ensure that the right sources of data, the quality of data, as well as everything that is needed on the ground is provided in a one-stop shop, so that not only are we improving the services, but most importantly, what can be done at a policy level? Because at the end of the day, that's really important. You can keep doing work at the local level, but you really need significant shifts at a policy level. So through these initiatives, what one is really trying to show is that, yes, technology is definitely improving the health systems, but the health systems we are seeing are becoming much more stronger and resilient. And also universal health coverage is no longer an aspiration, but is becoming a reality because we are able to really ensure that the frontline communities can benefit from it. I think on our panel today, one of my expectations, Gabriel, is going to be that we delve into the difficult questions around scale, equity, and inclusiveness that you mentioned in your previous panel, because these are absolutely critical questions. How do we build trust and partnerships? Because that's the only way we will be effective. None of us can do this work alone. And how do we really work together to address these questions to have a better collective future that all of us are here for? Thank you.
Thank you very much. I hope the rest of the mics will start working. Thanks to Polly. So you've given two very concrete examples of how tech of one sort or another, and at least one of the two examples concern digital tech, really at the coalface at work in Asia. If I may now move on to honey. You get a second bite at the cherry, but this time maybe you can help us really identify by highlighting investment in novel applications or innovations that would benefit public health and UHC, going back to your previous comments in Plenary Zero. And I was so struck when you said inclusiveness, particularly in access by those medically and socially indigent groups. So can you give us some examples of how those novel cutting-edge innovations actually feed back into that inclusiveness you referred to?
Thank you. Thank you very much for inviting me again to this panel. So why don't I share with you two examples. One where we believe that the right foundation is on the right track to achieve access. And the other investment case where it hasn't quite lived up to that expectation, shall we say, just to extract the lessons learned. So as I briefly mentioned, we are a relatively young funder. We've been around only for 6 years. So the focus that we really invest in are around the vaccines, diagnostics, biologics, and therapeutics. Now, one of the diagnostics that we've recently funded, this group, known based in Korea, they've developed an AI-based platform to automate the entire process of staining red blood cells that are infected by Plasmodium parasites, which many of you, I'm sure, know, cause malaria disease, especially in this part of the world, as well as Sub-Saharan Africa and Latin America. So this small tabletop diagnostic platform uses AI to essentially count the number of red blood cells that are infected by multiple malaria parasite subspecies. So it was hypothesized that this platform could significantly support the lab personnel and technicians in malaria endemic regions. It would save them time in counting these infected red blood cells. And I myself have spent many long hours under a microscope to examine them and count them myself when I was a much younger graduate student. So that tool so far has been licensed by FDA, and our grantee has been having very positive conversations with the government of Nigeria and other governments in Sub-Saharan Africa that are endemic for malaria. So this is I say this very carefully because it's just being rolled out. So the jury is still out there in terms of assessing the true effectiveness in the most marginalized communities. But so far, it seems very encouraging that the way this product was designed, and it's also built in our funding proposal, an applicant needs to compellingly argue how you've truly consulted with the end users in the countries, and ideally, not just consulting, but co-creating, co-developing, so that the product characteristics do respond to the needs of the ultimate end user. So this is a positive example where at least we are getting feedback that it is indeed freeing up time for Sub-Saharan African lab personnel who could then spend their time on other more complex tasks. So here is a positive example. Now let's move on to an example that was less successful, that we haven't been able to continue our funding. So this proposal also was focused on developing an AI-based tool to interpret chest x-rays to diagnose a wide variety of viral diseases. And we've learned, just without getting into a lot of details, what we've learned is while using this tool in this particular context in Sub-Saharan Africa was hypothesized to be helpful, unless there are other critical components of making differential diagnosis, it was not useful enough. It added a huge amount of time to actually validate and train the AI-driven platform. And in the end, you still have to resort to other confirmatory lab tests. So the reason why I contrast these two examples is because the first one was focused on a specific use case that truly met the demands and needs and a problem that was expressed by the ultimate end users. So in this case, there was a path to equitable access because already the developer had in mind where such innovation would be needed and where such innovation would solve a concrete public health problem. I think in the second case, I think perhaps our grantee was a little bit too, for lack of a better word, but if I'm honest, perhaps a little too naive in underestimating the complexities in the local context where the developer team envisioned that this tool would be used.
Thank you, Hani. Very relevant lessons, especially when we mean to do good, but we can only do good and do well and do better if we look at the local context of the potential beneficiaries, which is really a key lesson that we learn every day and relearn every day as we try to make a difference in the world, particularly from the philanthropic angle. So with that, let me move on to Thomas. Thomas, you are going to give us the 2.0 version of this amazing example of a statewide digital future, particularly as it applies in health. Estonia has been a shining poster case for many of us. Tell us what it is now doing to move towards this Gen AI future.
Well, thank you. As you introduced me, I've spent most of my professional life in international development, but happy to speak today as a citizen of Digital Republic of Estonia, as the New Yorker magazine called our country in 2017. I think the first thing to be clear about or make clear is that e-health or digital health in Estonia is just an application of e-society, e-economy that is based on the core digital society architecture, unique ID, the X-Road or XT, as we call it in our own language, for secure data traffic, secure authentication of our digital identities, interoperability, not only within health sector, but between sectors. So it is like an iPhone operating system or Android. You can build all kinds of apps on it. You can build e-school on it. You can build e-tax administration. You can you do e-banking. I've never missed a vote elections in Estonia, even I spent most of my time outside Estonia, because we can vote online. About half of the population does it so. So e-health, the digital health is just an application, and really important message is that if you have fundamentals in place, you can do anything on it. If you just go a step deeper into digital health, we have e-referral, e-prescription, e-ambulance, and of course, the electronic health record. And again, why is it important to say that if you have basics in place, then you can focus on health. You don't have to do the things that are complicated, difficult, and are outside competencies of the health people. And how we came to it, we didn't have enough money to try to attempt to build something big, a turnkey system that will answer all the functions. So I think that is the Estonian lesson to perhaps to the middle and low middle income countries, because when we started it, we were a middle income country. So on digital health journey itself, you said, give us a view of 2.0. I have to correct you, we are on 3.0. So our Our digital journey started with just digitalizing data, like many of us. It was 1990s. Then we started to integrate data. That data could be shared between two organizations. But now we are in 3.0. That to me is everything revolves. It's a patient-centered or person-centered digital health. Everything revolves around the digital identity of the patient, the digital health record that is sitting in the health and welfare center servers. It's not owned by any health facility, no any health provider, but they all can connect it to it. They are informed with the health data that is there, and they all have to add to that. And the patient, of course, now can also participate in his own health, can get the preventive advice from that portal, can decide what the data he or she would like to share. He can shut it down, but the default is open. That's where we have achieved reached now, and what is the current frontier, and a little bit going to the futuristic part that we heard earlier this morning, is that we have about 20% of our population genotyped. It has taken a long time, but just the last year we made this information available to the people. I think it's a little bit still some complexities to make it medical information, but at least the people can already now see the relative risks to some non-communicable diseases. And also perhaps more clearly and directly they would see their pharmacogenomic data, whether certain drugs would metabolize faster or slower, so that could also inform their medications. The topic is about strengthening health systems and universal health coverage. And universal health coverage stands on two pillars. It's service access and financial protection. And I think that's where we also, the pandemic turbocharged, of course, the telemedicine. Today we have 63% of primary healthcare visits virtual, about 15% specialist visit, and people are starting to complain it becomes too digital. Although going back to the morning presentation, I think we are just in halfway of that, and in terms of self-management. In terms of the health finance and what we can do, we can't get more money for health. That is always a global health question. How can we fund health? But we can get better value for money through digital claims management, automated controls, machine learning. That is already a standard practice in our public funder of the health services. I stop here.
Thank you, Thomas. Thank you for that 3.0 and peering towards N.0 version of the digital health experience and architecture of Estonia. And it's very interesting because as you describe this 3.0 version, you actually echoed the more generic observations of our two prophets from this morning. So you echoed essentially the platform architecture of what Ruben was talking about, and Estonia has in many ways already achieved that. And you also talked about now in 3.0, you've got pharmacogenomic information also incorporated into your EHR, which is at least one of the many omics in the Omics for All vision of Wang Jian from the opening first keynote this morning. Now, we've heard from all of our panelists here. You will notice, of course, from your phone or your little booklet that there are supposed to be two others. So let me just explain a little bit why they're not here. We, until 15 minutes ago, were going to have the privilege of a digital appearance by Minister Mohammed Ali Pate of Nigeria. But of course, as health minister of a very large nation in Africa, he had to excuse himself and been called to an urgent matter which required his immediate attention. And Jeremy Farrar, who's no stranger to PMAC, or indeed this region, the chief scientist of WHO, is part of the senior leadership team of the WHO, who have all been, as you know, completely grounded in Geneva in the last, or since the last week, because of certain geopolitical developments, shall we say, emanating from the Western Hemisphere. And of course, they are all now starting the executive board as well. So that's why we don't have the benefit of the wisdom of Minister Pate and also Jeremy. But what I would do is, instead of me quizzing and prosecuting my panelists here, what I would do is spend the next 18 minutes until your lunch break to ask you to please share your thoughts and really ask the questions that you had wanted to ask just at the end of the last plenary, and also reflecting on some of the things that these three have already pointed out. So again, there are mics dotted around. There are 6 mics, 2 to each aisle. So if any of you would like to ask a question, please come up to the mic, and I will call on you when I see you standing by the mics. Meanwhile, let me just start off by asking, look, we spoke about how we ground that envisioning exercise in Plenary Zero with concrete examples, and DePauli, you gave examples with UNICEF in this region and with the Pasteur Network in this region. Hani, you gave a lesson learned as well as a positive achievement, contrasting what we should learn from the delta between the two. And then Thomas, you gave us a whirlwind tour of 1.0 to now 3.0 and then towards 4.0 of the Estonian experience. But could I just take you back and say, look, yes, you've given us examples, but how would you tie in and inextricably link Gen AI and digital tech more broadly with UHC? Thomas has been the best in terms of his dress sense because he's got the UHC umbrella on his lapel, just above his SDG pin. So maybe we start with you, Thomas. Tell us how, other than in your native land, how the rest of particularly low-income countries, how can we leapfrog, and how in the upper middle and the high-income countries should we be facilitating that transformation so that low-income countries, those who are in most need, could actually leapfrog even the rest of us?
We get this question often, because I didn't mention that Estonia is a big country. It's 1.3 million people, and we saw numbers presented earlier, like you do go to one city in China and you get 1 million individuals of data. So, and we get this question, so what can the world learn from a small country? Because it's easy to do in a small country. And I just, anticipating Mohammed to speak as well, I just counted that Nigeria is like 200 Estonians, or India is 1,000 Estonians. But just I would like to say that doing the lessons learned is doing the fundamentals first. And I think very quickly we want to leapfrog to the 4.0, not having fundamentals, and then we end up with a narrow and fragmented application that may work until the donor support is there. But if you can build, when you have fundamentals, then there is a chance for sustainability. For the international community to refrain to support freestanding apps. We have funders in global health that they have very specific interests and they need data for their funding constituencies to show that their money is having impact. And if the digital or data systems are weak in country, they build their own and parallel. I would put investments into parallel freestanding information systems onto negative list and get everybody to support the fundamentals and building the more integrated systems. And finally, but where is a difference is the capacity. Is the capacity of, so before we get to the infrastructure, then I must mention legal environment, privacy laws and so forth. That's very important. But it doesn't matter whether you're a small country or a big country, the legislative process is the same, as complex in small country as in big country. So these two things in place, then the last thing comes to the capacity, to the people. And in the global health, we talk a lot about health workforce, but we should talk about digital health workforce as well. And this is not about doctors and nurses. Digital health workforce is, yes, the health people need to learn digital, but IT and developers, they need to learn health. Administrators, public servants, they need to learn about both together. The lawyers need to learn both together. And so I'm very happy that we have a small Estonian delegation here on this PMAC. We have like 2 people per million. But we have one of the architects of Estonian e-health system, but also the chair of the oldest digital health postgraduate training programs, multidisciplinary programs in Europe, if not in the world. So Peter Ross is there, so if you want to catch him, maybe you show your hand, catch him at the coffee break and see how to build a digitally competent workforce to advance digital health, so he has all the answers.
Free consultancy advice right there with Peter. Thank you, Thomas. We've got 2 gentlemen who have been patiently standing, waiting. Perhaps we go there first and then we'll come to the center aisle. Please introduce yourself.
Okay, I'm Han Jie from West China School of Public Health, Sichuan University from China. Thank you very much for the 3 speakers, as well as Dr. Lang's ideas sharing. They are very enlightening. We are talking about the potential improvement of the digital technology to improve the health. But we also encounter the potential non-benefits, especially maybe adverse effects on population health, like some new occupations created by the new technology, like the Uber drivers, like the delivery person. The planned, like the routine for the delivery man to deliver the goods. But in the real world, the delivery person may encounter many real-world problems to deliver the goods, but this would produce the occupational pressure and the potential traffic accidents. So what do you think about how we encounter these problems? My question is especially for the Henny. Thank you.
Right, thank you. We will take the second question and then we'll answer them together. Thank you.
Thank you. My name is Taufik Jordar. I'm an associate professor at Singh Health Duke NUS Global Health Institute. I'm also a board member of the Health Systems Global. So, you know, today's session is about harnessing technologies for a healthier world. And when we talk about healthy world or being healthy, it's not just about being physically healthy or receiving health care or treatment, you know. It's about how your health systems is organized to make the society healthy. So when we talk or we hear about the technologies contributing to health, most of these examples that we hear are about individual health care or to some extent health service delivery only. But my question to the esteemed panelists is that whether you can think of such technologies where our governance can be improved to enhance health, where our health workforce planning can be enhanced to enhance the population health, or maybe how corruption can be curbed in a health systems so that people get better care from the health systems overall. So this is basically my question. I want to hear your reflection about this. Thank you.
Thank you so much. So 2 questions at hand for our panelists. We don't need all 3 of you to give an answer, but 1 volunteer each would be great. So the first question really is about the human dimension of Gen AI, digital tech, or tech in general. How do we look after the corollaries and the consequences on human beings? Whether it's lost jobs, whether it's having to change jobs, what about those who are left behind because of the positive development of tech for UHC? So that's question number 1. Question number 2 is really about, hey, it's all great to do digital tech for better health for all, but fundamental to all that is actually buried in our title. It's how do we do it through health systems change? So can we do Gen AI or digital tech for governance processes? So who would like to take on either or both of those questions? Dipali?
I'll start with the latter and maybe try and touch on the first, but I'll leave it to Han because that was addressed to her. So I think in terms of the second question, there are examples that where technology is doing what you're suggesting, but I think it's not at the level of scale for a couple of reasons. I think, the more we can make the systems transparent through technologies where data is being provided in real time and going all across the system to the highest level to back. So it's not just about upward accountability. I think where things are kind of not really working out right through some of these technology innovations is that the access to data and the information is not necessarily flowing back, and the downward accountability piece is not really happening. So the more we can bridge the upward and the downward accountability through digital innovations, there'll be more transparency in the system and really making it open source so that it's not just the Minister of Health who's looking at the information, but everybody in that community, in that city is able to access just exactly how much money is being spent on what has been the impact and results, how is it really advancing UHC or not. So I think the more we can invest in that, the better it's going to be. I guess also, going back to your question, again, going back to the earlier panel question that you had posed to us, it's so important that we really talk to the people who are really impacted the most. I think some of us are kind of living in one world where we're developing technologies and we're doing things for people that we know what they really want from us. But the more we can spend time really understanding what are we trying to solve for and what is really needed, then we will be able to have technologies that are really working to advance the problems that we are trying to address. And I think that's where we some of us get very impatient because it takes time to really get to the heart of the problem. I'm not a tech person. I really don't know what tech can offer. I can tell you what I struggle with, but the time that it needs to be taken in terms of bringing these two worlds together is absolutely critical. And really making sure that we're inclusive and not just talking to the elite, we're really getting down to that Uber worker who's coming from a very marginalized community is going to be really critical.
Thanks, Dipali. Hani, over to you.
Thank you. So to respond to the first question, and if I heard your example correctly, and I'm really thankful for this example because South Korea is grappling with this situation, if I heard you correctly. So as it was mentioned during the first panel, AI, just like any other innovation, is a double-edged sword. So just using this AI-driven app and how it's being used in South Korea, it has helped customers enormously in ordering food conveniently and receiving food when you want. Now, as an unanticipated side effect, it has caused a huge strain on the workers who had to deliver as quickly as possible, and the nasty interactions with the customers if you fail to deliver because they're literally tracking you to see how you are not being able to deliver on time. So this is where I'm stepping back as a funder. This is where I think funders, and especially funders like Right Foundation that really focuses on funding technological innovation, to be humble and to have some critical reflection on multiple drivers to develop and ensure a healthy society that the second questioner mentioned. So in order for us to ensure that an innovation serves not just the health of the privileged, but the public health at large, that requires us to pull levers that are outside the realm of biomedical intervention. So even though I myself have been trained as a scientist and my organization funds vaccines, therapeutics, and diagnostics, I think it's extremely important for funders to recognize the inherent limitations of the area that you happen to prioritize, because that means you are implicitly deprioritizing some other areas. To go back to your question, to solve something like that, I think we really need to keep an open mind and acknowledge that we need to work with partners, allies, that we are perhaps not so familiar with. So to solve the problem of unanticipated strain placed on workers, we need to work towards an ensuring safe work environment for the workers, and that in fact goes way beyond just the realm of science and innovation. And I think in order for us to ensure that AI, like any innovation, serves the public and the society, then I think it's absolutely essential for people across different sectors and domains to come together with a good dose of humility and critical self-reflection to understand what it is that we contribute, but what it is that we have to rely on other allies and partners so that we really work towards a healthy society. And that's not going to be solved by just shiny tools.
Thank you, Hani. Now we've got exactly 2 minutes and 2 seconds. We've got 1, 2, 3, 4, 5, 6 questions. I will then take the chairman's prerogative and ask our panelists to go and answer these questions and give you a private audience afterwards, because we don't have time. But I will allow you to expose your questions in 20 seconds each. And then we will have to conclude because there are other sessions coming up even during lunch. So if we can just go from right here at the front and then go back at the queue and then end with the lady in the center aisle. Sir, 20 seconds.
Good afternoon. My name is Armin Fiedler, formerly from the World Bank and now advisor to the Austrian government. This panel is about innovations for a healthier population. And I think many of us in our heart are technocrats and get very excited about the potential. However, what I see in many of the high-income countries, there's now a backlash coming from the population, namely, anti-science, not trusting government, etc. So how can we, the question maybe for the panel is, how can we assure that in terms of leapfrogging, many of the low and middle income countries who want to catch up in terms of technological innovation don't fall into this trap that our populations are not caught in, that there's this distrust in government, distrust of system, and distrust of science. Thank you.
Thank you. Very, very apropos to the moment. Second question.
Hello, my name is Kritin Champrapab. I'm from the Thai chapter of the International Federation of Medical Students Associations. I would like to ask Professor Palu, especially, regarding how you mentioned a little bit briefly at the end of your speech there that there are certain people with concerns regarding the over-digitalization of Estonia and how Estonia is becoming too digital, per se. So I would like to ask, therefore, what concerns do you think are worth addressing, and how do you think Estonia, or any country for that matter, would go about addressing those issues?
Thank you so much. And the third question?
Hi, my name is Dr. Sipsan from Faculty of Nursing, Mahidol University. And I have a question, like, in Thailand, we are fortunate enough to have the universal coverage. However, in the view of nurses, I see like the lack of the central system database to connect the data from one hospital to another hospital. My question is that how AI and technology can help to facilitate in the development of the interconnect database, like especially in Thailand or others country that doesn't have. Yep, thank you.
Very important question. Thank you. And the fourth one?
Hi, my name is Nacha Sahaya. I'm a representative of Thailand IFMSA. So my question is, with the improvement and development of technology, including AI, do you think that one of the connections necessary to establish this is technological literacy? And in the panel's perspective, how can we improve or elevate it? Thank you.
Thank you. Tech literacy amongst the young. And the fifth question?
I'm Sexton Yosanit. I'm the health policy researcher from Faculty of Medicine, Rama Civil Hospital. So I can see that we now know that the gaps that we want to implement the AI or Gen AI with the health system is to find the bridge. But however, I'm researching on the evaluating the USC scheme, and we can see that there's tons of more gap. For example, the data is not centralized, or more than that, the implementation itself, how can we actually use those data to actually make an impact on the USC in terms of advancement? So I would like to listen to some of the practical examples that we can utilize these big data that we have in our hands to advance the USC scheme. Thank you.
Thank you. Asking for more examples than already given. And the final question to the lady in the middle.
Hello, I'm Zhihui Li from Tsinghua Vanke School of Public Health. I'm based in Beijing. So I specialized in social determinants of health and efficiency of development health assistance. So during my research, I observed that for many new technologies and interventions, when they emerge, the better of population will benefit first. So during quite a long time of period, at least some period, that the equity status will worse off because the intervention will gradually benefit those like less better off population or the more disadvantaged population. So giving the digital interventions, is this something that will naturally happen as well? And during this process, to what extent should we be worried about the equity issue? Thank you.
Thank you. More on equity. Now, we've got 6 questions, 3 speakers who will give you a specific and individualized, contextualized answer. But in the absence of which, and before you leave, just give me 2 more minutes. Don't go for lunch yet. They're not serving until we're finished. So, 2 minutes. First minute is to give you a general answer to the question that we posed at the beginning of this session. We don't have time to give you the individual answers, which you'll get during lunch, but a general answer now beckons if you actually look, because we asked ChatGPT what the answer to our original question is. Could we play that, please?
Ladies and gentlemen, innovative technologies like AI, big data, and digital health solutions are transforming public health and accelerating universal health coverage, or UHC. AI-powered diagnostics and telemedicine expand access, while predictive analytics improve efficiency. Automation eases administrative burdens, and AI-driven decision support enhances clinical accuracy and workforce training. Big data enables real-time disease surveillance and evidence-based policymaking. AI also advances medicine discovery, optimizes supply chains, and enables personalized medicine. In health financing, AI streamlines claims processing, detects fraud, and enhances sustainability. Strong governance ensures ethical AI use, addressing digital disparities and privacy concerns. By integrating technology strategically, we can build more efficient, accessible, and resilient health systems, bringing quality care to all. Thank you.
I hope you all agree that we're not quite at the point of singularity, that the panel has done much better than ChatGPT in answering the overall question posed at the very beginning of this plenary. Please now spend your next hour wisely before we thank the panel. There are 3 things going on other than lunch. One, there is the Thai government will be sharing its experience of its journey in the last few decades towards UHC. So that is going to be a special event. If you go out, turn right, walk towards the window as if you are going to jump out the building, you will see that place. And from 1 to 1:30, you will hear Thailand's own journey towards UHC. Well worth your time. Then from 1:30 to 2 in the same place, the WHO Western Pacific region, in partnership with the Institute of Philanthropy, is going to launch a new initiative in an end-to-end solution for NCD management, particularly in the Pacific Island countries. So those are the 2 special events from 1 to 1:30 and then 1:30 to 2. And then you will see poster sessions where you will get quick-fire poster Q&As during lunch. So please do go and visit those poster kiosks because they have spent a lot of time preparing what are really excellent outputs. And with that, please thank the panel in the usual manner and have a great lunch.